Thank you, Mario. Yes, I feel I have a great responsibility just now because I'm the one that's between you and dinner. So I'll do my best. Thank you very much. So I'm going to talk about the management of severe asthma and the management of the comorbidities. So this is my declaration of interest. So the definition of severe asthma has gone through various phases, but the basic tenet of the definition hasn't changed. But I think it will change in the next version. I think hopefully in the next couple of years we're going to discuss a new definition of severe asthma. But so far as 2016, we still go by the definition of a condition of asthma that do not respond to current medication that we usually use for treating asthma. And one of the slight changes that we had in the definition is that we now consider somebody who has severe asthma, even if he's well controlled, on medication, because the medication that we use to control asthma, particularly steroids, and particularly systemic steroids, is associated with a high incidence of side effects, of important side effects. And that's why, at the moment, well-controlled asthma on high dose treatment is still considered as being severe. But that might change, and this is a change that's probably going to happen as we get new treatments that are much more efficacious and that are associated with much less side effects. So as you can see there, so we're talking about patients that are at step 4 and particularly patients at step 5, a patient on a GINA stepwide guidelines. So GINA has also now got a special section on patients with severe asthma, which is the first time, I think that appeared in 2014. And of course, in the management of patients with asthma and particularly with severe asthma, you need to make sure that you to confirm the diagnosis of asthma. And all those of you who are clinicians seeing those patients, you know that very often you get the patient that comes up as a diagnosed as severe asthma and yet has an upper airway obstruction, very often a tumor in the large airways that mimics asthma and mimics severe asthma because they don't respond to the treatment that you're giving them. So you need to investigate for comorbidities, and that's another new addition here. And we'll talk about that a bit later. Of course, you need to check inhaler technique and medication adherence, and investigate for persistent environmental exposure. And I think this is an area where I think there's still a lot of progress to be made, and how we investigate this, I think, is still something that we need to put some thought. And you will see here occupational asthma, of course, has been well worked out to a certain extent, but you need to make sure that you keep this at the back of your mind as a potential cause for the asthma. So the management of severe asthma is also another. The drug management is also a part of the guidelines here. So optimize ICS LABA. A complete resistance to ICS is rare, and I think that's an important point. What you get in severe asthma is certain degrees of corticosteroid insensitivity. So you don't get this complete resistance, not responding at all. You need to consider therapeutic trial of a higher dose of ICS or even of OCS, oral corticosteroids, to know what sensitivity to steroids patient is. This is another thing that we now tend to use a lot more in our clinic, using low-dose maintenance oral corticosteroids, despite the fact that we do not have good data on how this low-dose maintenance oral corticosteroid therapy compares to taking intermittent high-dose oral steroids for those patients who do have recurrent exacerbations, as many of our patients do have, and some of our patients do have exacerbations nearly every month. But we do consider this is useful, because we do see some amount of success, but again, we don't have good studies, and I don't think we will ever have any studies that will compare those two different types of treatments in the patient with severe asthma. So the management also includes attention to side effects, and I think one of the progress of recent years has been able to do bone densitometry scans and to use prophylactic treatment for osteoporosis if you know your patient is going to be exposed to a lot of oral corticosteroids. Add-on treatments, which you can add without phenotyping, and you can see here this is another new thing in terms of GINA 2014, which is the introduction of phenotyping, the word phenotyping here. Okay, so add-on treatments, theophylline, LTRA, with limited benefit. And I think for LTRA, we do have some good studies indicating that addition of LTRA at that stage, at step 4, is probably not very effective, and limited data on theophylline also. Tiotropium, I'll come to that in a minute because this is probably one of the recent advances. And then the phenotype-guided treatment. And so that's been put here as sputum-guided treatment to reduce exacerbations and or treat steroid dose. And we know the problems with sputum production. Not all patients produce sputum, even and the induction with hypertonic saline. And so that's not a really practical a practical procedure. And the latest progress on the anti-IG treatment with the omalizumab, and then the phenotype of aspirin exacerbated respiratory disease, where you'd consider add-on LTRA, for which there's some evidence that LTRA is beneficial for people with aspirin exacerbated respiratory disease. Then there are non-pharmacological interventions that have been introduced, and more recently about bronchial thermoplasty, and a comprehensive adherence promotion program. So the rest of my talk is going to illustrate some of those points here and go into more details on some of those points. Right. And I want to illustrate this by giving you some data from the UBioPred severe asthma cohort. As you can see, for the severe asthmatics here, we have about 400 severe asthmatics. And some of the characteristics of those, a particularly severe group of patients, because 50% of those patients are taking regular daily oral corticosteroid therapy, and you can see that they have a high amount on average, sputum eosinophils, 2.75 versus 4.13 for the smoking severe asthmatics, and a very high levels of nasal polyps. This is about 35%. So 1 in 3 of those patients do have nasal polyps. And I can tell you, in those patients that are taking oral corticosteroids, 1 in 2 of them have nasal polyps. So I think nasal polyps is a very characteristic feature, comorbidity of severe asthma. Now, what I wanted to show particularly is the medication those patients were on. So these patients were recruited approximately 4 years ago, because we now finished UBioPred. So these recruitment were about 4 or 5 years ago, and you can see 4 or 5 years ago what sort of medication these patients with severe asthma were on. I mean, you wouldn't be surprised for most of those, but what may be surprising is the amount of tiotropium. 1/5 of them were on tiotropium at a time when those studies that were done on severe asthma that were published in the New England Journal of Medicine and other journals had not yet been published by that time. So tiotropium, very much before we had the hard evidence that they were effective, were already being used in 1/5 of those patients. And I bet you that now this 20.9% is much higher as a result of those studies. So there's short-acting anticholinergic, 7.3%. And anti-IG therapy, which had been introduced only probably about 3 or 4 years beforehand in Europe, 12.6% were an anti-IG therapy. So this is one of the studies, in fact, one study which focused on patients with this definition of severe asthma on high-dose ICS and LABA, and also using oral steroids, theophylline, leukotriene modifiers, and also anti-IG antibody. So this is your step 5 patients, fairly obstructed, 54% predicted, with a raised ACQ. And you can see this, even then, you're getting an additional bronchodilator or an improvement in FEV1. But also what is interesting in this study, although this is a very small effect, but it's a small significant effect in reducing exacerbations. And that's why there's a lot of interest as to whether tiotropium may have some, in quote, anti-inflammatory effect that might explain this reduction in exacerbation. Otherwise, you might have to postulate that something in that bronchodilator opening up the airways may be responsible. But we don't have time to discuss this anymore. So at the moment, our patients with severe asthma, I think it would be fair to say, on a combination of ICS, LABA, and LAMA. And so it would be interesting to see when we get the triple therapy in one inhaler, how this will fare. And of course, there's 50% of our patients in UBioPred are also on OCS. So this is the typical patient with severe asthma. So now I want to just spend just a bit of time about these approaches to asthma phenotyping, because it's now mentioned in the guidelines. And so I guess one of the reasons to go for asthma phenotyping is that some of the phenotyping that I presented this morning indicated that the age of onset is a biomarker of the disease, in the sense, for example, the early onset is very often atopic and allergic, and the later onset is more heterogeneous. They can be atopic or non-atopic. You have the asthma, the aspirin-sensitive asthmatics in that group, and more likely to be on oral corticosteroids. So there are biomarkers, but I don't think, so the biomarkers that we have at the moment would include blood eosinophil count. I think sputum eosinophil count, or sputum, measuring inflammatory cell in sputum is quite difficult. There's FeNO, which we like to mention, IgE, and atopic status. So there are now studies suggesting that improved treatment responses when using phenotype biomarker to guide therapy. So there's improved treatment responses, and particularly this has been shown for use of steroids, both inhaled steroids and oral corticosteroids. So those that have an eosinophil count or an eosinophilic type inflammation measured either in the blood or sputum will respond to steroids. I think that's quite clear. In fact, this observation dates back to 1975 for sputum eosinophils, a paper in the New England Journal of Medicine, and also dates back to 1960s in a paper in the Lancet by Morrow Brown. So, now, in the ERS ATS guidelines, one of the questions that we asked was whether sputum eosinophil counts should be used as a biomarker. And in fact, the recommendation then at that time, so these are a bit old because these were published in 2014. The consensus, the recommendation was that treatment guided by clinical criteria and sputum eosinophil counts performed in centers experienced using this technique rather than by clinical criteria alone. So this was the recommendation. And of course, at that time, there wasn't as much studies on those, but the recommendation was to use it in centers that would be experienced in this technique, because the technique was difficult in many patients, and also you needed to have the technical support to analyze the sputum and do the counts. So mainly used as a research proposal. Exhaled nitric oxide, we found very little evidence that we should be using it at that time. So clinicians not use FeNO to guide therapy in adults and children with severe asthma. It's severe asthma. And as you know, in the UK, we are now, in fact, using FeNO at a very early stage, and NICE, which, as you know, is the NHS arm that advises doctors which drugs to use and how to approach disease diagnosis and so on, has recommended that we use FeNO to diagnose asthma and also, to a certain extent, to monitor response to treatment. So we can use that, and particularly at the primary care level, but we are not advising at the moment to use it within severe asthma. So I think there's still a bit of flux about what biomarkers and how to approach the use of biomarkers in patients with severe asthma. And I just want to show you the outline of this RASP UK Clinical Stratification Program, which is a program that's been approved by the Medical Research Council in the UK, which actually addresses this exact question. And this is a program that's led by Liam Heaney in Belfast. There are about 12 or 15 centres involved in this for recruiting those patients. And the protocol here is, first of all, to use this combination of FeNO, periostin, and blood eosinophil. So we're using a composite of 3 biomarkers to first stratify the patients, first stratify on the basis of adherence, because we know that in severe asthma there is a lot of misadherence, or a lot of problems with adherence. It could be mainly because, or it could be that patients forget, or it could be that patients couldn't care less about taking their treatments because they feel that the treatment is not helping them. I mean, that's, I think, is also another issue. But Liam Heaney has developed this FeNO suppression test, which will be used to detect non-adherence, and that's one use of FeNO, which still needs to be proven definitely, and will be proven or not in this program. Then once you've gone through this loop, then you use these composite biomarkers to determine your T2 biomarkers high. Because we now know, we're now going to have drugs that are going to be efficacious on those T2 biomarker high. For example, anti-IL-5, anti-IL-13, or anti-IL-4 receptor alpha, which are probably, well, anti-IL-5 is certainly coming later this year in the UK, and the others probably later on. And so these would then be into the T2 high. But for the T2 low, this arm is going to be used, because the reason why somebody may be T2 low is because they may be over-treated with steroids. So there's a program here where the steroids is going to be gradually reduced, and the response in terms of those composite 3 biomarkers will be measured until some of them will become T2 high. Some of them will still stay T2 low. So this is, grosso modo, the type of stratification program which we believe is going to be helpful in the long-term management of those patients with severe asthma. So now I just want to go through very quickly through the anti-Ig antibody, which we've had now for about 8 to 10 years, and we know that it is efficacious. This is the in the guidelines. We went and did a grade approach to evaluate the evidence, the improvement in the quality of life, and these include both children and adult studies with an improvement in the quality of life. So this is a number of patients that have an improvement in AQLQ of greater than 0.5 point, and also importantly the effect in the reduction of exacerbations. So again, both in adults and adolescents and children. So the recommendation that we had here is that there's a therapeutic trial of omalizumab both in adults and in children, and this is not far off from what NICE guidelines suggest, except that the NICE guidelines do put a much higher hurdle to this recommendation. So they have in fact said that they would favor particularly patients who are on oral corticosteroid therapy and who are getting side effects from oral steroid therapy, and also those patients need to have at least 4 exacerbations in the past year. So a very high hurdle compared to where the recommendation or the practice that there is, for example, in the US. There are two things that I wanted to mention more about omalizumab, and I think these are in relation to severe asthma. First, the effect on nasal polyps. And this work from Klaus Bachert show that there is a very good effect on polyps and all the symptoms associated with polyps. And what is interesting from that study is that it doesn't matter whether you have an atopic background or not. And both groups respond equally well in terms of nasal polyps. So I think this is an example where anti-IgE would be also targeting one of the common comorbidities of severe asthma. So the other aspect, which I've just alluded to, has been shown in this study from Paris, from Professor Humbert in Paris, where they looked at the effect of omalizumab in severe, difficult to control non-atopic asthma, and showing evidence, although this is a relatively small group, evidence of improvement, as you might expect, in people with severe atopic asthma. So both the improvement in FEV1 and the reduction in exacerbation rates. So the question is whether this treatment should not be given to also non-atopic asthma, severe asthma. And now finally, I think one of the things that I think is important that come to light in a retrospective study, which is to look at what could be the biomarkers of response to omalizumab, because the biomarker that we use for treatment of omalizumab is not a biomarker of response, but it's a biomarker of allergy, I guess, the level of serum IgE, and then the presence of allergy. But I think this study indicates that if you use blood eosinophil count or FeNO, these would predict a significant percentage of patients that will respond to it. And the best biomarker here by far is the FeNO, 53%. Versus 32% for a high blood eosinophil count. I can't remember what the cutoff point was. And serum pyrosin also was also just valuable as shown here. So I think this is valuable information as to indicate who are going to be biomarkers of response. Now I won't go into the other phenotype targeted therapies because I'm going to talk about those tomorrow, but certainly there are going to be therapies where we need to define the phenotype of those patients that we're going to target for this treatment. Now I want to talk about bronchial thermoplasty because this is now trying to be established for the treatment of severe asthma. And when we wrote this in 2014, or when we analyzed all the data in 2014, or it must have been 2013, these were the studies that have been published regarding bronchial thermoplasty. We're now in 2016, and I don't think there has been any further studies that have been published so far. And amongst those 3 studies, the number of patients with severe asthma that have been treated with bronchial thermoplasty has been, in this RISA study, 15 patients with severe asthma. And that was an open study. And in the AIR2 study, which is the biggest study, which is a sham study with 3 bronchoscopies done, but the heating of the airways wasn't provided, there were probably about 30 or 40 patients that you would define as having severe asthma. And yet the treatment now is being given to patients with severe asthma. So those studies our analysis shows that those studies do cause an improvement in AQLQ, in the quality of life, an improvement just significant probably, or just outside a level of significance in terms of improvement of asthma control, but very little hard data. In one of the studies there was a slight reduction in the number of exacerbations, and also in the AIR2 study there was a profound effect of the effect of bronchoscopy alone. And our recommendation at that time was that we recommended this performed in adults with severe asthma only in the context of an institutional review board approved independent systematic registry or in a clinical study. And the reasons why we said this was that we weren't quite satisfied that the amount of evidence that was available at the time, we weren't confident that the evidence was as strong because of the low numbers of patients with severe asthma, particularly, that had been treated and had been observed. And therefore, we suggested that we follow up in through a study. I mean, you can only follow up patients if there is some form of institutional review board or it's in a clinical study. Otherwise, it can't be done. And the other reason why we recommended this was because of the high incidence of side effects, and particularly with the treatment itself, that occurs acutely within hours of the treatment. And in fact, that has been borne in mind now since the treatment has been available. So, and in fact, you can see here the recommendation was on avoiding adverse effects and on increased use of resources and a lack of understanding which patients may benefit. And so there's been a lot of excitement about this treatment.
Sorry, but you must go to the conclusion.
I must go to the conclusion, yes. Because of this observation, which we do not understand what it means, the reduction in the amount of airway smooth muscle mass. The only thing to say here is that you see the reduction in airway smooth muscle mass not only in the airways that's been treated, but also in the airways that not been treated, the middle lobe, which is usually not treated. So the significance of this is not clear. We don't know how it works. And we also do not know which type of patients would respond to that sort of treatment. So I don't have very much time to talk about the antibiotics. Very quickly to say that there is evidence now that the microbiome is abnormal, and particularly in patients with severe asthma, on high-dose treatment with oral steroids. And therefore, there is the issue as to the use of antibiotics, and I think there's one study of Guy Bruxelles, I don't know whether he's here, which was published now a few years ago, which didn't show any effect on exacerbations, but if you look for patients that have non-eosinophilic asthma, defined by this blood eosinophil count, then in that group, there is a beneficial effect compared to the other group that have eosinophilic asthma, and begging the question that maybe there is a category of patient of non-eosinophilic asthma that would respond to azithromycin. We won't know, and so our recommendation was not to use macrolide antibiotics yet, but there's a big study that's going to be completed in Australia with Peter Gibson, which probably will give us the answer to this. Now, comorbidities, well, I won't have time to talk much about this, but one has to address those comorbidities. Although we know, for example, with gastroesophageal reflux, we can treat the gastroesophageal reflux, but the evidence that it improves the asthma is very much unclear. And I think there are probably only two of those comorbidities that we probably need to talk very quickly about: sinusitis and obesity. And I've already shown you that treatment of rhinosinusitis very often could lead to an improvement in the asthma. And now obesity is another thing that's being very interesting to study. It looks as if there may be two types of obesity: an early onset and a late onset asthma associated with those obesity with different mechanisms. And of course, the only treatment that really would be effective in those people is to lose weight. And this is probably one of the best results that have been shown in this relatively small group of patients that improve in terms of symptoms, improve in terms of FEV1, although this improvement may just be a sort of mechanical improvement, if you like, but also an improvement in PC20. And what Ann Dixon finds here is that those people who improve in terms of the PC20 are those people who have normal IgE, but not those with high IgE. So even here, we have to phenotype our patients probably for bariatric surgery. So just to conclude then, I think in severe asthma, it's going to be important to phenotype severe asthma for management purposes, but the biomarkers that we need to use are not entirely ascertained, how we use it. We need to understand comorbidities and interaction with the asthmatic process. Treating comorbidities would seem to be important, but whether it does improve the asthmatic condition, that's still a big question mark, depending on the comorbidity. And I think these sort of approaches will certainly lead to better outcomes. Thank you.
Thanks a lot. I know, Fan, that this was a very large topic, so you had to take your time. But since it's very late, I apologize to stop the meeting today, and see you tomorrow.
Yeah.